So she, yeah, I think started by you. Let everyone know you're being recorded. Da 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 da. Okay, right. So that's that, and then we can share this. Everything I'm saying is coming up typed on the right. I'm just gonna switch that bit off so I don't have to look at what I'm saying. Okay, so that's our email address. So we've done the Mentimeter. I'm just going to give you, like I said, a quick update, and then we've got the ARFID team doing their next bit. If you've got any questions, put them in the chat, because Kate and Emma will do their very best to answer any of those questions. And you've also come up, you've put ideas in the Mentimeter, but equally you can put them in the chat as well for future topics. So what are we working on at the minute? Okay, just to give you an overview. In response to feedback and in response to our learning, the slides that we use in the training are constantly being updated. Okay, so we are adding in additional information that we think would be helpful for users of the profile as we go. So we are actually on version 8 and version of the training slides, and version 4 of the parent slides, for those of you that have sort of had a look at those as well. So we will make sure that we replace any outdated versions of these slides we've got services for schools primarily on that platform, so we will replace those with the most recent ones. But we are learning, and we are having conversations with people all the time to sort of try and find ways that we can sort of support the rollout of the profiling. I had a meeting with NHS England yesterday to look at a possible digital version of the profile. I know that many people have been asking if there is such a thing. So that is currently being explored with regionally, and I was told as well yesterday that if we don't get any traction regionally, they think it's appropriate to take it to a national level to find a solution for it, given the fact that this isn't just something Cornwall's doing. This is something that's being explored nationally, because many places are finding themselves in the same position as we are in terms of sort of demand for assessments, etc. I've run 3 focus groups with schools, which have been incredibly helpful and informative, and on the back of those, we will be, as a neurodiversity service, we will be writing an action plan with very clear sort of things that we need to put into place to support profiling. Your feedback that you gave in the Mentimeter quite clearly highlights the capacity issues that have been driven by the demand for profiles. So we are exploring what we can put in front of profiling. So we're looking at a sort of a neurodiversity roadmap that we can put in front of profiling, because I think what we are sort of hearing is that it's almost like some sort of corners have sort of forgotten what they previously used to suggest before we had profiling, and they're recommending profiling is the sort of automatic route for to find a solution to the child's needs. So we will be putting together an action plan. I'm going to do one more group because there were people that couldn't come to the last 3. So I will be doing another one, and this is something that we need to build and share. There is a potential pilot in the wings for supporting home educating parents who obviously don't have that scaffolding around them in relation to sort of having the sort of schools, and actually a lot of them are not really engaged with any other professionals at all. So we're looking at a volunteer pilot in West Cornwall. I've done the proposal for that, to support EHE families, and then if that's effective, then looking at how we can roll that out beyond that. We've got a group, October or November, I can't remember which one it is, to actually just review the content of the neurodiversity hub. In particular, we've been asked to create a tile for tics, so we need to think about content for that, but equally making sure that the rest of the areas that are in the hub have got the most sort of current sort of position information in them, so that when you are actually looking at it, you have got the most current versions of things. Training's still rolling out. I've just got a couple of slides of that in a minute. Parent information sessions are also running fortnightly, and a lot of parents now have taken to insisting that families attend those sessions before they will initiate a conversation around the profile as the next step. So that means that when they arrive at that conversation, they're not pre-aware, they've got a good understanding of what it's looking at, etc. So so those are actually getting a lot more popular. I think I had 22 parents at the last one. We've been asked to produce some guidance around what should a plan look like, how much detail should you put into a plan. So that's something that we are going to address, is to produce a sort of follow-up session from the initial profiling training, looking at sort of a plan. And I think linked to a point that sits below that, we are also going to generate a library of completed profiles, anonymized completed profiles, so that you've got a bit of a benchmark in terms of what you're aiming for in terms of content and detail, etc. There is a steering group at the minute exploring the possibility of having a family support worker workforce as part of the pathway to support families at home in terms of being able to implement some of the sort of advice and strategies, etc., that have been recommended. Some parents and families need a lot more support in terms of putting that into practice. So so that there's a meeting tomorrow about that. So we hope that and timescales I'm not sure about, probably the next financial year, but in which for us starts in January, in April, in terms of actually having that family support workforce. The behaviour tables that many of you have sort of commented on, that actually are quite weak in some areas. We've had a small group working on those. They will be ready at the beginning of next term, Cornwall's version of those behaviour tables. So we have filled in any gaps and provided a lot more clarity in the areas, and attempted to make them more sort of standardised. Lucy Yeoman's here; she's been working on that. Those schools that are involved in the PINS school project, which is about promoting that sort of inclusive neurodiversity sort of approaches in schools, that the sort of state of that is they're sort of currently putting together the menu for training, etc. So you will hear fairly shortly if you are one of those schools. The Autism in Schools team have actually got an advice line now. I've put Lucy gave me the link to your sort of web page, so you can click on that to access their advice line. So that is there. In terms of data, Kate kindly provided me with the data, just to give you a flavour of what's coming in. So as of the beginning of September, we need to update it, obviously to reflect the end of the month. But in terms of requests for consultation, there's been 243 that have come in since the 1st of May, okay, which is a big difference. I appreciate that in terms of what we used to get in terms of requests for diagnostic assessments. However, a lot of sort of practitioners have been looking at that 12-week sort of consolidation implementation period, which is probably, you know, held back some of the requests for consultation. But equally, what we're mindful of is we need to think about how we are organising this, because if schools need to be part of that consultation process, we need to think about how we operate that within a term time framework as well, to catch those individuals. So in terms of requests for consultation, as of the sort of beginning of September, we had 31 that were waiting to be screened, and requests for consultation that were completed and discharged with advice, we had 24 of those. And then in terms of the request for consultation completed or considered discharged and referred on to diagnostics, so that landed in diagnostics, there were 43. Just to give you a sort of, the data is all very new, okay, it's all very new, and we're sort of gradually trying to understand patterns and the nature of the requests that are coming through as well, Kate, isn't it? Because we're just trying to get a handle on what is it that people are actually looking for from us in terms of help and or diagnostics or whatever. So
yeah, and it's still a trial at this point, because with anything you need to just kind of almost launch it and then just sort of tweak it as you go along, based on, because at first you just never know what you're going to get through the front door. So so we're sort of adapting as we go along and as we learn more about the kinds of requests that we're getting. But I know that as of yesterday, I think it's 51 now on the new waiting list for autism and or ADHD assessment.
Okay, that just gives you a bit of a an idea. But yeah, like I said, we are learning and responding accordingly as the project progresses. So just a little bit about training. So I think the content is largely hitting the mark, okay, in terms of I think most attendees feel as though it's pretty much covering what they need to know, but equally the way that we're running them, people feel quite positive about the level of interaction and the sort of virtual groups, which it's always you take your heart's in your mouth when you press the button and hope they'll head off to their rooms and land in a room. There's always at least one or two left behind, so they end up having the privilege of working with me in terms of looking at the case studies rather than doing it in their own group. So that's just a snapshot in terms of what's coming through on the training. And then that's what I'm saying, the slides are evolving as we go, because we get feedback every time from the training, basically, because no one gets their certificate until they provide their feedback. But anyway, so we have a lot of feedback in terms of what's positive, what they felt was positive around the training, but equally looking at how we can improve it. So this is where some of the sort of the drive for looking at something to help people with, you know, how do you write a plan? What should a plan look like? How much detail do you need to put in it? Because this is not specialist level. This profile is not around. It shouldn't be about requiring sort of specialist level of knowledge. It's about primarily looking at the neurodiversity hub, and for those of you that have got that sort of additional experience, adding in your sort of knowledge and experience into that as well. So so we've got both of those. We're sort of picking up on those and responding accordingly. Again, just a bit of a plug here as well. Homestart Kernow have been around for a long time, and we have commissioned, or not me personally, but the ICB have commissioned Homestart Kernow to provide support for parents and families. And a lot of this is dependent, is sort of using peer-to-peer support, so parent-to-parent support. So they notified me this week of some of the opportunities that families have got out there that they are delivering in terms of support. So they have an online group. The posters are there, but they've got an online group which is the second Thursday of every month, and that's for an hour. I've actually been along to that one, and I think Charlotte Price has also done that one as well. They are doing a face-to-face weekly group starting at St Dennis Family Hub to just see how that one runs. You don't have to live in St Dennis to go to that one. If parents want to go to that one, that's open to any parents. And then they've got what they call roaming groups in different venues across the county. So if you want more information about any of those, you can check those out on those links. So that's everything we are doing at the moment. We're pretty busy, as everybody is, but I think, like I said, we are doing our very best to be responsive and hear what's happening out there in terms of the impact of the pathway changes, so that we can then think about how we can best respond and provide support. Thinking about whether family workers could be part of that solution as well, in terms of supporting families who are sort of struggling. And this might help where we've got situations where parents are requesting profiles because they're experiencing quite sort of a lot of challenges at home, but actually the schools aren't experiencing the same challenges within that environment. So it's about thinking about whether we need to do something different there as well. So that's me. This is what we're doing, and hopefully that just gives you a bit of an idea. But like I said, any questions, we'll take any questions in that email that I put up at the beginning. If anybody has any specific questions for me or the team, you can just email in, and we will respond. We will respond to you. We're dealing with lots and lots of inquiries from parents, as well as some from professionals as well. So, okay, well, that's all I needed to say, because my bit's not the most interesting bit, I think, really. I think my colleagues have got the bit that is more interesting, but hopefully that just gives you an idea of, like I said, what we're doing. Right, so I will stop sharing, because what we've got now is we've got this. I know Courtney's not saying anything. I think she's in the background, isn't she? But anyway, I put her name on there just so people have got her name. It's out there anyway. So this is just an introduction. I'll let Julie and Carenza introduce themselves in a minute when I take this down, and then I will leave it in your capable hands. Just before I do that, has anybody got any questions for me before I exit my slides? Nope. Okay, right.
Katie and I have been manning the chat, so I think we've addressed everything in there.
Perfect. Okay, excellent. I will stop sharing, and I will hand over to Julie and Carenza.
Hello, everybody. So my name's Julie Dutson. I'm the specialist dietitian with the ARFID team. My sort of background has been working as a dietitian with children with disabilities, so sort of all sorts of neurodiversity, including autism, learning disabilities, and physical disabilities for the last 16 years. So I'm quite new to ARFID team, but actually we've been dealing with restrictive eating for a long, long time, and particularly restrictive eating in autism. I'll hand over to Carenza to introduce herself.
Hi, I'm Carenza Jones, occupational therapist. So I've worked previously in RCHT in the Children's Community Therapy team. And more recently, my role before coming into the ARFID service was with NDAT, the Neurodevelopmental Assessment team. And so, yeah, this new role in ARFID sort of brings all of that together, really. And we've had the opportunity to be part of service development. So, yeah, we've got a little bit just to sort of talk a little bit about our team and a bit of an introduction to ARFID. But there's so much that we could talk about. So we've tried to just give a bit of an introduction today, but if any teams would like a little bit more of an in-depth kind of insight into ARFID and a bit more about the team or any specific topics, then that's something that we can offer at another time to any team.
I'll start with sharing our presentation. So if you just bear with me whilst I set up from the beginning. So I'm aware that actually, I should start from the beginning. So I'm aware that lots of you have probably come across our team already. I see some familiar faces where we've met with your teams or yourselves to talk through what our service is about. So for those who haven't come across ARFID, it stands for Avoidance Restrictive Food Intake Disorder. And this issue of avoidance in children, it can happen in adults as well as children, can happen right through the ages. Normally we sort of start picking it up when they're 3+, but we are sort of seeing children a little bit earlier. But this is we'll talk through just what the diagnosis is, but also sort of how we get there. So there's a lot of input through Cornwall around selective eating. And I think ARFID sort of became a new diagnosis back in 2013. But before that, we've known that children have been restricted for a long time. I think the funding followed this food restriction when the selective eaters started to hit the headlines. So quite a few years ago, we started with a story about a boy who in Bristol had permanent vision loss because he lived on chips. He was actually of a normal weight, but overweight, but his diet, he was really restricted with his diet just to eating chips alone. And when they sort of came across him, nobody had really picked him up early. They came across him because of his eyesight loss, being really unaware of sort of how that had happened, and he was just very, very deficient in lots and lots of vitamins and minerals, which weren't obviously part of his diet. So ARFID has now become a word that families know. And following that, there's lots and lots of different services, private and sort of NHS, that are starting to look into ARFID and provide a service. So in Cornwall, the government sort of provided commissioning boards with money to deal with ARFID, and from that, a local STEP programme was rolled out, as well as a new ARFID service. So you will come across parents who are very much aware of selective eating and the word ARFID. Why should we be worried about children? So I've mentioned the story of the boy who became sort of partially blind and permanently partially blind, but we've also had recognised deaths in this country from ARFID. So there was a 7-year-old boy 2 years ago that died. He was found to be very, very malnourished. So ARFID can, sort of the problems can be quite invisible, with invisible health impacts on the child. And why should we be worried? Because our children need more than is in their diet sometimes that is being provided. So the pictures that we've got here on your left-hand side are actual food lunch boxes that are sent in by parents of really of children who are really restricted. It's not to say that these foods will be eaten, and this is a school lunchbox. This is to provide that child from 9 till 3 with nutrition. But this is the desperation parents will go to just put anything in that child possibly would like, has liked, and possibly will eat. The children that we see would not eat all of that, but we also have similarly some overweight children who would eat it all but still be really deficient in nutrition. So we classically think about ARFID as selective eating as those children eating a beige diet, but it can be anything. It can be children who actually just eat apples. We've certainly had those. It can be children who are just at the age of 5 having transitioned off from like stage 2 or stage 1 weaning foods. Pouches are quite popular, and a baby's bottle. So we certainly are seeing, we've had those in Cornwall for decades, and we've certainly seen them come through the ARFID service as well. So the issues that sort of happen is not necessarily always around weight and growth. What we can have are, significant states of malnutrition in a child who could be overweight or actually of a normal weight. And we have a picture of a little boy with a blue top there with patches of hair loss, and that was purely nutritional. So he's a boy in Cornwall. We have classically, the lips that you can see with chelosis, that sort of granulation on the side, is actually not an infection. That's B vitamin deficiency. So we've seen stages of that, and obviously some changes to the nails caused by zinc and selenium. We also see lots of dental caries in children with selective eating. The little picture of the boy standing out in his answer depicts the social isolation that these children have when they've struggled to eat alongside others, or not part of that sort of big party of food. And the bottom picture, which looks quite grim, is about thinking that these overweight children, these children that can have restricted diets and that can be overweight, also suffer with the health consequences of their obesity. So our projects that we have in Cornwall, there is the LEAF, which is learning, eating and lifestyle, and the Q project to deal, that's the complications of excessive weight. There are two projects that look at children from age 2, like sort of infancy right through to 15 now, and they are picking up type 2 diabetes, type 1 diabetes, and fatty livers in these children who are on restricted diets. So they're predominantly eating high calorie foods with very little vitamin and mineral content. So that's sort of why the girl boy in the middle is just shows that the paleness of some of the children. Iron deficiency is really common in when you start getting children with selective eating. I'm just onto the slide. So this is like teaching grandma to chew eggs, but it's sort of this slide is about what happens in normal feeding development. And anybody who's attended the STEP, I think Lucy did say that you've attended the STEP program. That is a program that's rolling out. I'll talk about. We'll have seen this slide. So STEP is something that I was part of creating and getting out there. So if we think about how a child should normally be eating, they start with getting ready for obviously sort of an inherent instinctive need to feed, so they will latch on really quickly onto a bottle with a good suck. So this is normal healthy feeding. When they're ready with good head neck control and able to sit with some support, and they're showing an interest in food from 4 to 6 months, but generally nearer 6 months, then we'd be expecting them sort of to develop onto some solid foods, and that could be a puree with finger foods, but they can generally manage that food quite well. And you might get the odd cough or choke, but that sort of quickly resolves, and actually they move on again, and that's just part of their learning mechanism of starting to feed. By 6 to 9 months, these children should really be ready for lumps in their mouths and manage to sort of move food around their mouth well and sort of chomp down on it, so they can actually manage with mashed foods and lumps and finger foods. And really, by getting up to 12 months old, they should have really developed a good chew, good hand-eye coordination, so to allow self-feeding, managing chomp foods, so minced and chopped family foods, and harder finger foods. So you'll see a 9-month-old happily sort of just munch and gum their way through apples, and so the feeding skills can appear quite well developed in young children. So by the age of 3 to 4. Children should be entering school, being able to use utensils, being able to manage a whole range of like sort of chewy meat, right down to a sort of a thin liquid that sort of they manage to control in their mouth. So that would be normal feeding, but really by 4 years old they can manage what we'd consider an adult meal. So the critical points that can go wrong are that with your baby. So starting with that sort of that neonatal period, that you've actually got some adverse feeding experience. So that could be that you've got a poorly baby. They've sort of had perhaps just a viral infection, sort of a chest infection. The premature babies, they've had lots of interventions with tube feeding. We might get reflux in babies that actually every feed makes them feel can make them cry. It can give them pain, and lots and lots of other medical issues. So like a cardiac baby, a baby who's sort of struggling for a chesty, or a cardiac baby who might be struggling for breath a little bit, needs some surgery, but they feeding on a bottle is really difficult. And the story I sort of give here is a little baby that I saw on years ago when I was working, who wouldn't feed very well, needed heart, sort of had a congenital heart defect, was born with a heart defect and needed surgery, and they were really struggling to get this baby to feed. And I visited, and this poor mum was trying her best, and she got the baby ready, tore off a piece of kitchen roll, because she knew she was going to have a battle with this baby trying to get this bottle, the teat of the bottle, into the mouth. And as soon as the baby heard the kitchen roll being torn off, so something not really very distinct, started screaming. And so this baby had already developed, this relationship with feeding, that actually there was a prompt that made the feeding episode was so traumatic for this baby that actually even knowing that it was coming could start the baby crying. So really, it's more medical issues that you'll see in the first stage that start impacting on feeding. There's if by 6 months our infants haven't been fed, they've not had experience of food in the mouth, then actually that really causes problems later on in life. So delayed weaning is no good. There's lots and lots of studies to show that does cause feeding issues much from then on. Delayed weaning in that they're not being exposed to a range of foods as well. So if you keep a baby on purees past the 9-month mark, they are going to be much more likely to have a feeding problem as well. Now, going through that toddler phase, when children are going through their natural neophobic phase. So, again, we've got to think about your basic instincts. At a toddler phase, a child would be moving away from their family. If we're looking at a sort of caveman tribal sort of situation. And so that toddler moving out and picking up any food, really putting it to their mouth, will have a natural instinct to sort of spit out bitter tastes, particularly because if you were a caveman baby and you picked up a bitter tasting berry, it would be highly likely to be poisonous to you. So there is a safety mechanism that's sort of introduced around this 18 to 24 months of age, when actually a child should naturally become a little bit suspect of food, and particularly new foods. So that is very, very natural in feeding development. And if the child hasn't been helped through that phase and guided through that phase, then that will cause problems as well. So those children not being helped to progress through that phase where they're going to have a preference for sweeter foods or familiar foods is going to have problems. And if the child has anxiety, so later on we're looking at, say, more of a traumatic one-off episode of vomiting, or a traumatic episode of choking, or they've got pain like unresolved an allergy, then those kind of mental health and those physical problems can cause pain, but they tend to be more specific and easier to spot. So it's thinking that if you're back to your children, if they do have problems early on in life, they're much more likely to have a feeding problem later on in life. So it's really knowing to ask those questions. So this is, again, something that we should all know when we're looking at, sort of say, even talking through with parents and doing the ND profile, looking through, what the child's experiences are, what makes up that sort of child's health program. It's thinking about sort of how well do they eat. And the thing that I sort of say is that to be healthy, you don't necessarily need to eat everything that's in that picture at all. So we can have children who may eat 2 or 3 vegetables, or they may have a juice and 1 vegetable and 1 fruit. They're eating, some starchy carbohydrates. They've got some cereal. They've got a bit of bread in there. They've got some yogurts. They're not a big milk drinker that leaves the milk in the bowl behind, but they'll have plenty of yogurts. And they will have some baked beans, or they will have some egg. And what you'll get, sort of, if you've got a child just even with, say, 8 or 10 foods on that plate, but they are a good variety of foods, you can still have a diet that is repetitive and balanced, repetitive, but is still a balanced diet, right? So as long as they're meeting those food groups, you can still actually, with fewer foods than the picture there, and certainly fewer foods than most families should be eating, could be eating, then it can still be healthy. But our problem is the selective eaters you've got you're probably alerted to because they're missing one or two groups off that Eat Well plate. So that's a good, Eat Well plate is a good way to sort of think about what should I worry or shouldn't I, right, alongside other factors. So I'm going to hand over. Clarence, do you want me to carry on with this, or do you want to share? Have you got PowerPoint open? About. Oh, is this me still?
Yeah, I think were you going to carry on and just do
carry on. Oh yes,
steps?
yes, that's right. Okay, sorry. Yeah, no, sorry, I just need to remind it. So we have. So we're looking at ARFID today, so avoidance restricted food intake disorder, and the one thing to say is that it's actually quite a broad definition of diagnosis. So you could get very low level selective diets in there that and very high level selective diets in there. So there are lots of reasons why a child may actually develop ARFID, and there's lots of different severities that they can come across. So just as it says that ARFID is different for everyone. So there's different. So when we're looking at ARFID, we find mainly that there are three big drivers to it. So to bringing those children out. So we're not sort of looking at big trauma episodes, or we're looking at these kind of sort of pictures, big family trauma episodes, or these kind of pictures. So a common driver is sensory factors that Trends will look into in more detail later. We also have the driver of lack of interest. So children just come to us or come into selective eating with just a low drive to eat. So it's even with their favourite foods, there's still quite a lack of interest. So they still need to be encouraged with even their safe preferred foods, as we call them. And then you also have the driver of an anxiety, of a fear of a consequence. So this might be a child who has choked on something, or may have seen somebody else choke on a food, or have a fear of contamination, that they're going to be ill if they eat a food. So the main thing to say is that the condition is characterised by these drivers, and what we end up with is a restricted diet in terms of quantity and variety of foods eaten, or certainly the variety of foods eaten need to be there. So it is much more common. We're sort of going to cover into autism and neurodivergent people sort of later on. So these are the diagnostic characteristics and the criteria. And you'll see when I sort of say it's actually very broad, it is, and we could come across all children. So it's a lack of interest, avoidance based on sensory characteristics, or the aversive consequences of eating. So they are afraid something about food makes them anxious. So we have to sort of say, is it about food? If you have a child presenting and they're anxious about everything, is food just part of that picture, or are they specifically about food? And we're looking at the real specifics around food. That's when they sort of are diagnosed with ARFID. So that, as I say, could be everybody, all of your selective eaters out there. So what we have to sort of define it down to is sort of saying, actually, as part of that, are they suffering from weight loss or obesity? So we do sort of say that actually they're nutritional, because we sort of see in children who are morbidly obese, there is a significant health issue there, but weight loss is what we see much more commonly. Are we seeing a nutritional deficiency? So are they known to have iron deficiency anemia? So they're eating loads of cereals, their weight is fine, but they're actually, they have deficiencies in their diet, vitamin C deficiency, iron deficiency, vitamin D deficiency, and we see lots of that. There's lots of little things that they are missing that can cause ill health. Is there a dependency on enteral feeding? And that could also mean supplements as well as tube feeding. So are they reliant on tube feeding to keep them healthy, or supplements to keep them actually at a healthy weight. So their weight might be fine, but actually they've got heavy reliance, and we do see this. And we've got quite a few children out there who are on oral supplements, their Pediasure, their juice-based drinks, that is just propping them up. So those are the main things we see. And is there a marked interference with their psychosocial functioning? So is the food, this is related to the food, their anxiety or their sort of interaction with their food, is that affecting their welfare out there? Is that affecting their social life, their engagement in activities that would be part of a healthy well-being child? So to exclude other issues, we've got to make sure that it isn't around a lack of food or a culturally sanctioned practice. So we're not sort of ensuring that there's fasting going on, or that actually this child's on this diet because parents are vegan and so they become anemic because parents have decided you've got a vegan diet that's not balanced. So we need to make sure that actually it's around the child's food choices. The second thing that we need to really exclude are any inference or cognition around anorexia or bulimia. So the child is clearly presenting that this is not around body image, body weight or shape in any form. And that's very clear, with lots of our children. We do get some children who have ARFID who into their teens become more aware of shape and their body size, but it's thinking about what sort of came first. And the final exclusion is if this eating disturbance is in any context of a medical condition or another mental disorder. So if they've got, sort of low level sort of a psychosocial sort of disorder, that wouldn't be, or say an OCD that's affecting all of their life, that food isn't just part of that mental disorder. Medical condition, as I said, sort of thinking about whether they've got, a food allergy going on, and that's sort of all uncontrolled reflux, and that's what's making them not want to eat. Okay. And there's various conditions as well that actually chromosome disorders that cause poor appetite and low interest in food. So when we're looking at the restrictions or a restricted diet, we've got to think about the contributing factors. So this is forms part of our triage, is sort of when we're looking at these children and thinking about what pathway do they need. So in the middle you've got this child with a complex feeding disorder, and we've got to sort of rule out some of these things and include some of these things. So if this child is vomiting, is that sort of down to a medical condition? Is it down to dysphagia? We might look at their thinking style, or they're ritualistic. We can look at their sensory sort of problems, or their sort of sensory drivers there. Alongside the sensories, their self-regulation, and hunger drivers in there. As I said, the medical conditions affecting appetite, the abnormal gut function. So we do get children with reflux. We've got a lot of children with calcium protein intolerance that have come through our way. We have a look at abnormal sensory input. So what is currently happening to them, what has happened to them. So a bit of history around their experiences. And so there's quite a broad picture that we're looking at. And some of the things, as I said, if it was a medical condition affecting appetite, we would exclude them from having ARFID. We'd sort of say that's much more down the line of a paediatric feeding disorder. If it's poor tone with dysphagia, then we'd actually be sort of saying that needs to be addressed first. But and if it's abnormal gut function, we need to be sort of addressing those things. So some of these other factors need to be cleared first for us to say, well, what is the impact now on this child with their eating? Okay. Right. So the next two slides are really, really busy, right? And I just kept thinking about how on earth do I reduce this? But this is essentially what our service is. And what we do and how we decide where children go. So I'm just going to take you just across the green. We'd be saying, if we had a referral in this as severity interpreted, what we're interested in is the weight and growth and physical development of this child. Are there concerns or no? And as we go down the levels, we sort of say there's more concern on that child being morbidly obese or that child being really chronically underweight. We're then really interested in the nutritional adequacy of the child. So these are questions you'd ask yourself if you were doing the the neurodiversity profiling tool and thought, right, I've got a problem. Mum's saying that this child is not eating and drinking a range of foods. And these are the sort of kind of questions you need to be asking yourself. So you look at the weight and growth. What is the nutritional adequacy? Are they eating from all the 5 food groups? Mum's still worried, but actually they're managing that. What is the impact on the young person's social and emotional development? This is the impact of the eating restriction. Are they able to participate in normal activities? And they just, you just know that they like what they like, and that's what they can stick with, but they can go to school lunch and have their chips on a Friday. Or are they impacted that they can't even take their food to school, or they can't eat in school because they can't cope with the sensory aspect of it, and food is something that's at the very edge of their ability. We also very much need to look at the family functioning, because we have some households where the child's lack of eating really affects the whole family. There's high anxiety. You've got parents who've had to become a primary carer to a 4-year-old who can't go into school because they are the only person that the child will take food off. So there's a massive impact on the family in that kind of situation. And so this goes from the green right down to the red. Right, so we go through 4 phases of checking our children, and we're more than happy to share this. But we're looking then at something called the MEAD assessments. These are the children that are really malnourished. So we've stopped worrying about overweight. We're now really into being incredibly low weight and needing hospital admission, needing checks on. So it's medical emergency eating disorder at this point, where they need a check on their blood pressure, they need checks on their heart rate, they're severely malnourished, and the mental health issues around it are really significant. There's no food routine, there's increase in family emotion, violence, aggression, and breakdown, really. So that's how we sort of work. On what we've done, so just go back a slide if it allows me to. Right. So we've looked at sort of, in theory, what could be some of the supporting services around these children. This is where I feel this is useful. This sheet is useful for anybody out there sort of wondering, what do we do with these children? They're quite low level. They wouldn't meet perhaps an ARFID team, because we can't see every single child with selective eating out there, but what is available. And there's lots of signposting. There's groups that families can join that with other parents that have similar children with selective eating, and there is a STEP program that's being rolled out. So I'm just aware of time. So from a point of how we're doing, so from a point of sort of what we'd like to happen in Cornwall, if we look at our old-fashioned triangle with sort of a base of just increasing complexity of our children going up, for universal sort of children, those lower-level children that are early intervention, younger children, there is a training offer from the community, the RCHT dietitians in the Children's Community Health Therapy Service that I was part of, and we created this program called the Steps to Eating program, and that is a local offer that can go to anybody. So it's at the moment it's been run out still to early years, but there is the plan for it to run out to school age and to parents as well. And it's really generic advice. A few of the slides I've used here, but really generic advice about sort of stopping the problem before it becomes a big problem. And it's about identification of these children with selective eaters, and some good just basic strategies that a nursery, a portage worker, sort of early inclusion worker could put in place, health visitors, family support worker could put in place, TA, sort of could put in place around these children at a low level to stop the problem from becoming further. When we have these children, some of the bad ones at 4, but a lot appear at 6, 8, and about 12 when they're really then difficult to treat. It's a lot more psychological interventions, whereas actually some generic family and peer intervention around them is really useful at a lower effort. So that offer is out through Steps to Eating program, and that's available through Cornwall. But as I say, it's only early years at the moment. What STEP offer is also, if there's a selective eater and you're thinking about escalation, there is a STEP offer for some consultation following attendance on the Steps to Eating program. So you can actually speak to a dietitian if about a particular case, but at a lower level of complexity. Our service sort of comes in at the top. So the children, young persons, ARFID service is around those children that are at more risk. So you might have tried some step with them and they're just not getting through. The eating is far more ingrained and having an impact on their weight, under or over, their level of nutrition, not meeting those 5 food groups, and certainly showing they need some supplements and missing out on vitamins and minerals at least, their impact on the child and the impact on the family. So those 4 sort of indexes that we looked at, and that's where that we'd need a referral through to us. And we do have a website that we can share at the end that has lots of signposting information and information on how to refer to us, right? So
thanks, Julie. Do you want to keep going, and I can just sort of say when to move on to the next slide? I'm just conscious then we.
Okay, right.
Oh,
sorry,
got
the last one was just that.
Yeah.
That was last one was just a step model. So anybody who's been on step training will recognise that we do work with this model as well, very much so. Most services involved in selective eating would do. So I'll hand over to Corenza to talk more about our service now.
Yeah, thanks, Julie. So our service is still relatively new. We started taking referrals in April. So we've sort of had a bit of a 6-month period where it's a bit of a pilot period. We've been taking referrals and sort of getting an idea really of the demand and where those referrals are coming from, and basing it a little bit on the iThrive model. So thinking about what our service can offer at the moment, what resources we've got, who we've got in the team. And so this is kind of a bit of a general idea that we've based it on over the past 6 months. And we're sort of at the end of that now, so just reviewing things and how that's going. So within our team, really, we've got 3 core AHPs. So it's myself, OT, Julie, who's the dietitian, and then we've got Vicky Ford, who's our clinical psychologist. So between us, we kind of cover a bit of a 2 whole-time equivalent post, where we're all part-time and we split that across the week. We do have some intervention then from the paediatricians and psychiatrists. So we're trying to cover, like it says here, the whole of the iThrive model. So right from the getting advice stage, where if we look at a referral and we feel that we don't need to offer any intervention, what we would do is we'd put them onto our getting advice pathway, and that's where we would give some of the bespoke signposting and lots of the information that we've collated that we would then signpost to some of the parent carer workshops. We're in the process at the moment of designing our own parent workshop. So that's something in the future that we hope that maybe the getting advice pathway that could be an offer. But at the moment, there's actually some really good parent workshops already out there. Lots of good webinars that we're signposting to in the meantime. The next stage then, when we look at a referral and we're triaging, and then once they've come through to our clinic assessment, it could be that we offer an MDT consultation with the local team. So what we are saying on our referrals is that actually when someone's a child is referred into our team, is that actually we do need somebody who will remain as the nominated professional, because we know that actually the children that with ARFID, it's likely to be a long-term condition. So it is something that even if we do a bit of a bespoke intervention, actually these children and families are going to need to have that support long term. So actually working with a local team, possibly doing some joint assessments and having interventions that we could pass on to those people that are surrounding the child, it's going to be in the best interest of the child and the family. So that's what we're really encouraging, is that we work alongside other teams to support them into any interventions that we offer. The next step up from that really then is if we feel that following assessment that we do think that actually we can provide a little bit more kind of intervention within our team. And again, that still is alongside the teams that are involved, but it might be for a while that we offer some sessions. We're sort of offering up to 6 sessions initially, at which stage we will then review and see if there's anything additional that we can offer. And actually, this is something that we spoke about very recently. We did have a slide to share, but we couldn't quite get it across for today. But it's kind of looking at what those interventions will be and what those sessions will look like and what's going to be in the best interest for the child and the families and what that might look like. So some of them might be very general strategies that Julie, myself and Vicky, either of us could carry out for the family. So that might be looking at some psychoeducation, it might be around school liaison, could be around graded exposure, food play, and sort of those general strategies that any of us could carry out. We do also now have 2 therapy assistants actually that have joined the team, who are sort of getting involved now in the cases. And Courtney, who's listening today, she's our sort of most recent therapy assistant. So that's great that we've got some people that will be able to work in the homes and in the schools alongside the families as well. So the getting more help is really for those that we feel need a bit more extensive and specialised sort of goals-based help, really. And that's where we'd look at more specialised, maybe OT, psychological approaches and dietetic approaches. So I'll sort of go on into what those interventions might look like a little bit further on. And then the getting risk support are, again, where we would consider the MEAD guidance, which Julie mentioned about earlier, the medical emergencies and eating disorders guidance, and possibly looking at admission on the paediatric admission unit at Trelisk. Okay, thanks, Julie. So as we said before, ARFID is very unique for each individual, really. So it's really important that we gather a really full medical history. So what happens at the moment is, and this is where we've been sort of redesigning things, the child comes in, we do an MDT triage. So we sit together and we really have a look through the referral. We look through our risk tools that we've got, and we really sort of have a look to see, you know, whether we feel that that child does need to come through for an assessment, at which stage the first kind of assessment will be with a paediatrician. It's really important to get that really thorough medical history to find out what's going on. So some of the common features that you might see in a child or young person presenting with ARFID are all the things really that you can see on here. So a tendency, we see lots of children coming through with anxiety, and that isn't just related to food. So in other things that are happening in that child's life, you might see previous tongue tie, previous hospital admissions. There may be swallowing difficulties, choking or vomiting associated with food. Like Julie said earlier, dental complications, and sometimes for our neurodivergent children and young people, that could be really long-standing, could be sensory related in the fact that they really dislike toothbrushing. So it's really getting a really holistic assessment, and that's where our paediatrician really does a thorough medical history to get a real kind of idea about the characteristics and duration of the weight changes, take any medical history, family history, and look at different symptoms that we might see. Thanks, Julie. And as Julie said before, so a child might present with ARFID and they might have good growth. You know, somebody might not have many sort of issues initially. They seem to be growing quite well. But actually, there's those real chronic health issues, which Julie, I think you mentioned before, chronic constipation. And actually, when we do blood, so quite often actually with the paediatrician appointment, we will feel actually we need to have some recent blood so we can really get an idea of, you know, what's going on for this young person. And that's where we might see actually those micronutrient deficiencies that you wouldn't normally pick up. So it might be that when we look at the food diary, that all seems fine, but it's actually when we do the bloods that we can get that extra information. The growth delay, growth arrest, or like we said before, it could be that the child is overweight because they are having, you know, they've got excessive consumption of one type of food, and again that's causing that imbalance really, and that can lead to quite dangerous body imbalances. Pubertal delay and low bone mineral density. So they're all the kind of chronic health issues that we really need to dig a bit deeper to get a real picture of the child that's coming through. So then we're starting to think a little bit about the drivers. So as you might see a lot with ARFID, when we've mentioned this before, there's the 3 main drivers, and they're not pathways as such. I think it just helps to kind of give a bit of an idea when you read the literature. Not that there's no specific intervention at the moment for ARFID. There aren't any nice guidelines for ARFID. I think they're all in the process of being written and evidence is being gathered. But at the moment, what we can do is look at the evidence that we have got from other feeding clinics. We're all really engaged in meeting up and trying to be part of other specialist interest groups that are going on within psychology, dietetics and OT to really gather that information, as well as our paediatricians and psychiatrists. So we're looking at the drivers. So as we said before, it could be sensory aversion, it could be fear of the consequences of eating, or it could be a lack of interest. So if we think a little bit around the sensory aversion, we know that feeding is one of the most complex occupations that we have to do and that our body's required to do every day, because it involves the integration of all the different 8 sensory systems. So I've put them on here. You've got the tactile, visual, auditory, interoception, which is that internal sense, that really interesting kind of sensory system that you've probably seen a lot of now. It links a lot with ASD, and there's some lovely information out there all around interoception. Really, really fascinating sensory system. Proprioception, which is our sense of where our body parts are and knowing where you are in the room, where you are in space. Vestibular, again, which links to our balance and motion, and also where our head position is. And so feeding involves all of these. And so, as Julie said, that feeding development, usually sort of for neurotypical individuals, will happen quite naturally with all those experiences. So with modeling, with being offered different varieties of food, for neurotypical children that are able to sit at the table, they can hold their own posture, they can use their hands to explore food. That tends to develop quite naturally with all those experiences around. But for our neurodivergent children and young people, all that early stage of feeding development can be interrupted because of possible sensory sensitivities. And it can incorporate any of the 8 really that can lead to eating and feeding difficulties. So looking at a sensory experience of feeding, so these are just some basic examples really of what you might see in a child who is oversensitive. So it could be that they prefer beige foods because it's quite familiar, nothing really changes about it. It feels quite a safe food. They might cover their nose, or they might avoid certain areas. So at school, they might avoid the canteen. It could be extreme that actually they're not able to sit at the table with the rest of the family. They have to be in a totally separate room. They might need to eat only cold food because actually the smell of warm food is just too overwhelming for them. So quite often children might prefer food that's cold, so they can't actually smell the food as much. They avoid touching food, so quite often it might be that they prefer to use cutlery or actually want somebody else to feed them because they can't tolerate touching the cutlery. So again, the whole exploration of food is really being affected here because the child isn't just able to sort of experience and feel the food around their mouth and on their hands and on their lips. It could be environmentally, so that actually loud environments are really difficult. So that makes the child really anxious even before they're able to come and sit at the table or go into the canteen at school. And any sort of change. So as we can see in the photo there, so even though for a child they might be so used to having toast that's cut into squares that suddenly when it's presented in triangles, that doesn't look like their toast because of the shape. And that's a massive change for some of our children with neurodiversity. Some examples of undersensitivity, what you might see is that children might actually overstuff their mouth and pocket food. So it might be that they hold that in their mouth because it could be due to the proprioception and the muscles in the mouth that actually they can't register how much food they've got and how much to swallow. There's a really nice piece actually on the National Autistic Society around autism and eating differences. And it's Elizabeth Shea who's sort of written something, and there's she's taken an experience of a an individual, I think an adult at the time that she's worked with, who describes really lovely depiction about being able to eat and having to use a teaspoon, because she knew then as an adult, she knew how much to put in her mouth for how much she could register. So if she used something like a tablespoonful, she wouldn't be able to manage that in her mouth. And what she found is, you know, the food would come back out of her mouth. But if she knew she had a particular size of spoon that she could use for each mouthful, she knew that she would be able to manage that in her mouth and swallow it. But it took years for her as a child. It wasn't until she became an adult that she realized what was happening and what she was able to do. So I can put that in the chat, or share that at the end. Actually, it's a really lovely, gives some really lovely depiction about the sensory difficulties around eating with someone with who's autistic. It might be if they're undersensitive that they prefer strong flavors and crunchy textures. So we see quite a lot of children that are referred into our service who like barbecue flavor hula hoops. So it's that really strong flavor, really crunchy, but also the strong barbecue sort of flavor. And that's sort of a bit of a common theme for these children that are undersensitive. And these children might start to swallow food whole or not notice how to chew. Again, it could be linked to the proprioception and just the whole awareness of what food they've got in their mouth. Thank you, Julie. I could talk about that for a long time, so I will move on. So ARFID and autism. So this is just a really lovely diagram here, really, just to show what you might see. We've said before that feeding difficulties are more common in autistic people and individuals in relation to neurotypical individuals. So we can see there on the screen. With ARFID, you know, you've got a strong emotional response to food, and as we've said before, usually if the drivers that you think about are linked to sensory avoidance or maybe the lack of interest, they're usually ones that you might see that are a bit more of a long-term driver. Something like a fear of the consequences might be something that you might see that happens, you know, that is sort of a bit of a sudden event. So that might be something following a choking episode, might be a metaphobia where somebody's got a fear of vomiting, could be around contamination. And generally with those kind of trauma-based, that's something that isn't necessarily long-standing unless it's something that's happened when they were younger and it's kind of a trauma has sort of continued. So this is really nice, and maybe just a really nice slide to have a look at another time and just kind of just see the comparisons there between ARFID and autism. As we see in the middle there, it's about being brand specific, context specific. So it might be that a child will only eat certain foods in schools, and we definitely see that with the children that are referred. So for example, you know, a child that we see will only eat cookies, certain cookies at school in a certain seat with a certain teacher next to them, but actually won't entertain eating those cookies at home. Very specific on the different packaging. And I think we'll have a look next actually as to why that might be on the next slide. I am conscious of time, so I think we've got a few to go, and then we will allow a little bit of time just for any questions or anything anybody wanted to ask. So this is a question that we quite often think about, is why does a child struggle with fruits and vegetables and actually tend to eat the same? Typically, you might see that it's a beige diet, but as we said before, not always. So you do see, like we said before, we see children that do eat mixed textures. They might eat lots of apples every day. But generally, when we're thinking about this, it tends to be kind of a beige diet. And why is that? So as Julie said before, that neophobic stage is a real typical part of the feeding development. And generally, with opportunities and experiences, a child will move out of that. And for each child, that does vary when that might be. And some children continue to be in that neophobic stage for quite a while at primary school, but they do come out of that with experiences. But for those children with extreme neophobic responses, and quite often this does link to our children with neurodiversity, it could be linked to a real sort of hypersensitivity around the sensory systems. And generally, we see that around children who are hypersensitive visually. This, yeah, for those children that are showing this sensory hypersensitivity, they kind of will develop a greater anxiety around food and meal times. You'll see that they get increased hypervigilance, which is they're then less likely to eat or tolerate new foods. Yeah, so these children become really attentive to any sort of changes, any blemishes on foods. So you can see in the picture here that actually generally a cracker or a biscuit that's beige is the same every time. Unless, of course, if you try and introduce, for example, like a McVitie's biscuit that clearly says McVitie's, for these children that are really visually hypersensitive, that really notice every little change in detail, even the writing on a very similar McVitie's biscuit, they would refuse because even the writing on there is very different. And so we need to sort of consider, and again, there's some really lovely resources. It's called the PEACE resources, PEACE, and I'll share that at the end. But again, for our children with neurodiversity, it's thinking about the environment as well. So not just focusing on the food, but what's going on around them. So quite often for these children, the whole environment is just too sensory alerting. And so their anxiety is increasing even before they've got to the canteen or they've got to the dinner table or they've got to a meal time. And their hypervigilance is also increased. And so even before they've got to the plate or they've got to their food, they're at a stage where they're not likely to try anything new. And sometimes they even start to refuse their safe foods. So also for our children with neurodiversity, it's thinking about the cognitive differences. So we know that some of these children do like to do have real strengths in their cognitive differences. So it could be that they've got amazing memory for the topics that they're really interested in, but it could also affect their eating in the fact that they want to have food that's very familiar to them. They do become hyper-focused. So again, this attention to detail and anything that changes in their food becomes a big stressor for them and really increases that anxiety and that fear response will increase. And it's, you know, we see these children that like to have routines and rituals and things that stay the same. Yeah, so we've kind of thought a little bit, Julie's sort of spoken a little bit about some of the dietetic approaches, looking at the sensory approaches. We would look maybe, if we're looking in our team, we're then going to go on to the psychological approaches. Sensory wise, there are some things that we might look at in a little bit more detail for those children that are really, that we really feel need some bespoke kind of assessment. It might be that we really look at their sensory profile, that we do a sensory integration assessment and really have a look at what's going on around the whole kind of sensory system. So not just focusing on food, but again, looking at what's going on globally for that child. Some psychological approaches that they might look at. Thinking about some of the interventions CBTR, so that's cognitive behavioural therapy. And there is one that's actually been adapted for ARFID. EMDR, and that's something that our clinical psychologist has just done her level 2 training, so that's really great. So she'll be able to offer that to some of our children that come through, and thinking about family therapy and those family-based interventions. Julie, do you want to talk about the food diary, or I'm happy to sort of carry on?
Can you hear me?
Yes.
Yeah, right, good stuff. No, this is just an example, as I've just mentioned this one. This is one day of a child's food diary that's a real life food diary that was sent in to us of a child that we sort of seen. So this is a 4-year-old who's going into a special school. So he has got a diagnosis of autism. He's got a special education needs environment that he has to be part of, and there's lots of he's definitely sort of sensory, definitely lots. He's in managing quite smooth, although it's a 7-month jar, it's quite a smooth jar of one hypogallic flavour and smooth yogurts, no bits at all. So there's a lot of work to do with this child and family, because as you can see, the family being so desperate to get him eating that he's having well over 2 litres of formula a day. So this is just to say this is an example, quite a bad example of a 4-year-old's diet, but we actually do get, similar in that we've got 3 or 4 foods on that a child is actually eating. So it might just be crackers or chocolate and a milk. So we are sort of seeing children at this kind of level of restriction, and there's a lot of work to do with them to break that down, get them nutritionally safe. So for this boy, he is overweight, but also that level of formula that he's having is giving him far too many vitamins and minerals. So rather than being malnourished, undernourished, he's malnourished, overnourished with that food diary. So just to finish off, really, it's to sort of say, when you're coming across children out in the community, then just thinking about those red flags. We've given a bit of an idea of severity scoring for restricted diets. You can use that with any child about sort of, are they thinking about their weight, thinking their growth, thinking about their nutrition, thinking about the impact on the child and family. Just about sort of, do you need to probe more? The real red flags are that if they are underweight, particularly your younger children, if they are underweight, there's poor weight, or if they are really overweight. If they do have diagnosed nutritional deficiencies, they're ones to watch, because clearly they've got themselves there in the first place, and often getting vitamins and minerals into these children, a supplement, is really difficult. And particularly if there's any choking or significant reflux or mechanical feeding problems, then they're obviously a big choking risk at that point in time. So those are your red flags of the ones that you really need to escalate quite quickly. And the point of escalation would be going through their health visitor or primarily their GP, and then that referral could go on further. Okay. And
I think we've just got our signposting. Yep.
Yeah, there's a lot of signposting information there, so I wouldn't be expecting you to write all that down, but we've added a lot onto the Neurodiversity Hub and the Parent Care of Cornwall site, and there's a couple of specialised signposting for the ARFID awareness and BEAT, which is an eating disorders charity, and they have a lot of offer for parents and children with an eating disorder. ARFID is defined as an eating disorder. Right, so we'll say thank you for listening, and any questions, and I'll stop sharing. Right,
you got some questions in the chat, Julie.
All right, okay, we haven't been monitoring the chat. So
there's one about constipation.
Okay, let's have a look at it.
It's from Rosie. With the impact restrictive diet has on constipation and the amount of ND patients having to use laxatives, etc., to manage this as the diet isn't able to be altered, is there any advice? As it's also a presentation that's led to death in LD patients.
LD, yeah, it is. It's it's that sort of undiagnosed. Nobody really wants to talk about it because it's poo. It is a real problem, and it in fact impacts on the child holistically. So the thing that we sort of say is that actually that there's lots of information on the autism site about getting children to take medication. There's some really good websites out there for children with autism and medication, because I think when the diet is a long way to go. So there are more fortified whole lots of whole fibre milks and things like that, like the Weetabix milks and things like that on the market these days. And there's a lot more sort of tendency to health foods. So there's more fibre in lots of the foods nowadays. But really, it's down to fluid and the amount of fibre in these children's diet. And we know that that's poor as a whole in the population. So I think, if it can't be managed from a diet point of view, it's important that it's managed from a medical point of view, and it's about how you get that in. But there are some good websites, and the Autism Society website is good at giving some advice on how to get medications into a child. But but you need to get them passing the poo. So if the diet isn't, if you can't work towards an ideal diet quite quickly, you need to be doing that through medication. You can't have a child becoming impacted or a young adult.
Okay, and then thank you, Julie. And then there's another one. When's the next planned STEPS training?
Right, the ARFID team isn't. It's the STEP team that you need to talk to. So I think on the last slide, on the signposting slide, if I sort of just go back there again.
I can maybe
yeah.
help with that
Yeah.
question
Oh.
because we just had STEPS training as a team, and they were saying that they're hoping to roll it out to schools from about January.
So that's it. So it's
I'll
still
put-
got the
yeah. If I put the there you go, in the chat, I've just copied from our resources. So
Yeah.
that would be the email to it would be, it's RCHT, the community therapy team. So if you email that email address that I've added onto the chat, they'll be able to advise on the next step training.
There should be a step inbox actually. There is, so get your name down for if you're school based to sort of, and any services that sort of feel, you know, I keep sort of saying that after the pins, so it should be trained as well in steps. So that's, you know, lots of the very generic information and guidance, and that's the level that you want to go into. Yep. Anything else?
There's Emma says, I'm looking for support with a week-long residential trip with a pupil with ARFID. Would I need to make a referral or can I just chat to someone?
It'd be a referral, just because we're sort of quite an MDT at quite a high level. So it's also thinking whether they've got a dietitian already, or otherwise look at the ARFID awareness site, and there's lots of information there for, you know, health professionals, for schools, for, you know, so residential. So there's lots of information on ARFID awareness. That's an NHS site. It started with parents supporting, but there's a huge amount of professional information as well on there.
Thank you. Just out of curiosity, do you think ARFID is getting worse, increasing in cases each year, or are we becoming more aware of it?
I think ARFID, I think selective eating is getting worse. I think worse. I think COVID drove it. You know, so I don't want you to feel, I mean, could it go, Carenza, hand in hand with, you know, whether autism is increasing or whether we're recognising it?
I know, and I
Yeah,
think that's always a debate, isn't it, about is it just that we're recognising it more? I mean, with eating disorders in general, there was a massive increase following COVID. So from our colleagues across the country, we know that those figures have increased within eating disorders. And ARFID is classed as an eating disorder. So, and again, the links with neurodiversity. Yeah, that's something that we continually debate. So, you know, I don't know if it's getting worse or just the fact, you know, and again, nationally, lots of ARFID services are popping up now. And so there is a bit more of a bespoke service, you know, otherwise, you know, these children before, they didn't have services that they were recognised as getting support. So yeah,
I think, I would say
answer to that one.
I would say though, children's eating habits are getting worse. We know that with the rate of obesity, you know, and we can't always blame COVID, but COVID, there was a big increase in children being seen with obesity after they'd had lockdown for a while and just eat. But we know skills of home cooking, we know family meals, and you know, if we go back to that toddler presentation of sort of, you know, having to learn about foods, so becoming quite unsafe with food because you're neophobic, because you're actually venturing away from your clan and venturing away from that cave. And we know that children learn out of that phase by role modelling. And because we haven't got pet families sitting around a table and eating together, we're getting children really stuck in that phase. So I think the way that families are eating, we all know, is changing a lot. There's a lot more processed foods out there within, and a lot less cooking, lots less tables in family houses. So I think there's a knock-on effect to general selective eating in children. There's so many that aren't coming through that neophobic phase, and lots of anxious parents who are worried about other, you know, issues for their child, rather than sort of looking at the basics of sort of really good role modelling and family meals and guidance. So yeah, so it's been part of a societal problem as well.
Yeah. Okay. I think the rest of them are sort of comments.
Can refer 3 to 4 year olds. Yeah, we do see 3 to 4 year olds, particularly if you sort of think that they've got autism, they're highly likely. And
yeah, and I can see there was one there diagnosed in 2021, and that's, you know, there are lots of services now popping up. So unfortunately, there probably wasn't that support in 2021, but hopefully now, as services are developing, the support should be there now for children getting that diagnosis.
Yeah.
We can just double check. We can double check the checks. I know we've gone over. We can double check, and if there's anything we haven't responded to, we can get in touch.
Yeah, no, that's really helpful. Thank you.
I
am mindful of time and people having to go to the day job and everything. But thank you so much for that's been, I found it fascinating, really, really interesting. So thank you both very much for doing that, and for Courtney for manning some of the chat stuff as well there as well in the background. So okay, well, that sort of brings us to the end of the sort of session today. So we'll be running, we aim to run one of these every term. So we'll have a look at the topics that you have requested, and we'll see if we can match that up with, a sort of CPD opportunity for you, as well as sort of maybe bringing you up to date with some more of the stuff that's going on around profiling. But thank you very much to our speakers today, Julie and Carenza. And we will find, I think, a better way of notifying people of future communities of practice, because the way we tried for this time hasn't brought as many people in as on previous occasions. So, but thank you very much, and I will let everybody go now. Actually,
thank you.
Thank you.
Thanks, everyone.
Bye.